Hi, can you go over how to better differentiate the various blunt trauma injuries like pulmonary contusion, cardiac contusion, tracheobronchial injury, thoracic aortic injury? All right, cool, yeah. So let's just do a quick trauma review. This will be very kind of like to the point what you need to know to differentiate and kind of heck with everything else type of deal. So we'll talk about thoracic aortic injury, trach injury, cardiac contusion, pulmonary contusion. All right. Does anybody want to get us started here? What are kind of your thoughts, things that you think of when you hear these things?
Well, maybe the thoracic aortic injury would be any dissections, type A dissection, if there's a mechanism of injury in the question stem that gets us to that. I always get this mixed up. I don't know if it's hypertension, the patient would present with a hypertensive stats, the aortic dissection or not, but that's something I have a question on too also.
Sure. So with thoracic aortic injury, it's usually immediately distal to the left subclavian artery. And that's where the aorta is basically kind of tethered when you're in development. And so that's at the aortic isthmus, that's what they call it. And so what you're looking for is an intimal flap. This is kind of like the buzz phrase that they'll give you. Let me pull open, I'll show you aortic dissection. CTA. I'll show you on a CAT scan. Can you guys see the screen here of the CAT scans or no?
Yes.
Okay, excellent. So if you look right here, this is your descending thoracic aorta right here. If you see, you got two lumens essentially. So this right here is the true lumen. The smaller one is almost always the true. And then the bigger one here is the false lumen. You have contrast opacification of your true lumen right here. And so you can tell that there's contrast because it's bright white right here, right? And this false lumen here is not getting as much. There's probably some contrast retrograding upwards from or downwards wherever the intimal flap is and the fenestration. So let's look at some more here. You see this intimal flap right here? This is the fenestration of the injury. So that's basically where it has ripped through the intima. Find some more for you. Here's your true lumen. Here's your false lumen around it. And you also see this huge hemothorax here in the chest. You don't want to miss that. All that blood is sitting basically in the lungs where the lung should be, right? So if you look over here at the right lung, it's all black and basically shows clear airways. There's a tiny little bit of pleural effusion back here, which is probably just spillover from this hemothorax. And this is all blood right here in this entire chest window. Let's look at some more. There's a good intimal flap right there. You see very clearly the fenestration. 7 centimeter right here for your aorta. That's huge. That obviously need to be repaired. Thoracic aorta usually gets repaired at about 6 centimeters, or we'll talk about some of the kind of criteria for repair of dissections as well. But does this help you kind of at least get familiar with identifying the dissection flap there? That's super, super critical. If you guys are on rotations, you're in residency, or even on the exam, I've seen them actually test this with the dissection flap. You 1,000 trillion% need to be able to identify that. If you look at this 3D reconstruction right here, you kind of see this is the aorta here, and then this is the false lumen that's persistently sort of filled kind of retrograde up back to the left subclavian. This right here is the takeoff of your left subclavian, and so it's almost always just distal to that. Does that make sense? This right here is actually technically an intramural hematoma. See how it kind of forms like a crescent around the aorta here? That is, you can see that there's a dissection distally here. But up here, you see how that there's not like a compressed true lumen or false lumen. It's like the actual caliber of the aorta is there, but that crescent around it is what you call an intramural hematoma. That's beyond the scope of the step 2 usually. That's pretty much the big thing for being able to diagnose these if they give you a CTA. Like they could be able to give you 100%. Let me find one that's fair game for a USMLE level. They can 100% give you this right here, and you see that dissection flap right there. Or they give you one right here where you see the dissection flap right there. Those are all very fair game type of questions. So that would be aortic dissection. So if you have a blunt thoracic aortic injury, that's usually from like a hard deceleration, like a car crash type of scenario. Or it could be from somebody that fell off of like a 20-foot ladder and landed on the ground and basically sheared their aorta. There's different classification and grading for the aortic injuries. We won't get into all that. But to your question about will they have hypertension, will they have hypotension, that type of thing. And so usually you're going to have systolic blood pressure greater than 180 millimeters of mercury in these questions. Because it's the high pressure. If somebody comes in off the street, let's say, and they have an aortic dissection, Usually it's from the high pressure of their blood hitting that weak area of the aorta that just rips the whole thing. And so usually they'll have high systolics. But if they had basically like contrast extravasation, or they had hemothorax, like we saw in that one where the entire lung window is basically filled with blood, that patient could certainly be hypotensive because they've lost a lot of their circulating blood volume. So it kind of depends on the clinical picture. I can't tell you 100%. It's going to always be hypertensive in a question. But let's just say you had a thoracic aortic aneurysm and it ruptured. That patient's definitely not going to be hypertensive at that point, right? Because their blood pressure is all dispersed into their mediastinum, their chest, their abdomen, wherever the aneurysm's at. So that's something to think about. Some other clues that they can give you is different blood pressures in each arm. Sometimes I see that on step 2 tested where they'll say that patients, let's say left arm is reading a blood pressure of 90, and then the right arm is reading a pressure of 180, for example. And it could be because it dissected into the subclavian artery. So that's certainly fair game. That was actually in a UWorld question for step 2.
May I dare ask you a question? How do you differentiate that with coarctation? I mean, the age of the patient, but how is that different with the BP difference of different limb?
So versus coarctation. So let's do a little comparison and contrasting right here. So coarct is going to be congenital, right? So this is usually somebody who's got a long-standing history of fatigue with walking, meaning that their legs get sore from basically poor blood flow. They can have hypertension in upper extremities, but lower blood pressure in lower extremities. And so this would be, instead of a difference from one arm to the other, it's usually the arms would both be like, let's say 130, and then the legs would be like 90 or 80. They'd be substantially less because the coarct is going to usually be past the subclavian. And so both your arms would be totally fine, maybe even a little bit hypertensive because of the resistance of the coarct. But then your legs are not getting adequate flow, so your blood pressure would be lower to your legs. Does that make sense? And so usually a coarctation is not going to be acute. You don't just present out of nowhere with a coarct that is going to be causing super severe symptoms. And so if I saw something that was more of a chronic type of history, or something that patient has had this in the past, or they have a family member with this, or they have, you know what I mean, like that type of a deal, then I'm definitely going coarct. If it's a acute situation, patient has tearing chest pain or back pain, I'm going with a dissection, for example. And just for you guys' overall knowledge, this is very, very unlikely to be asked in this way, but you can actually dissect into any of your mesenteric vessels. You can dissect into your renals. You can dissect into your legs. So dissection doesn't have to just be up at the thoracic aorta. Like, we deal with dissections every day, and they can completely cause acute limb ischemia of one of your legs because it can tear down into your iliacs, and you can occlude the lumen of your external or iliac. So just for you guys is like actual real life medical knowledge, because basically no matter what specialty you go into, that's something that you could run into, whether it's IM, FM, EM, surgery. You're going to see stuff like this because so many patients have high blood pressure, and you want to really have that at the top of your differential. So this is going to be acute, and so that's a big differentiation. All right, who wants to go next for one of our other 3 topics? Good job.
Off the top of my head, bronchial injuries, you're going to have like subcutaneous emphysema, like crepitus, some palpation in the chest. You can also probably have like, not like altered lung sounds, possibly. Those are like 2 big things that stick out to me.
Yeah, I mean, you hit a lot of the big things there. If you see crepitus in a question stem, that's a lot of the time going to be some sort of an emergency, obviously, right? Like, they don't just give you crepitus and it's somebody that you send home and tell have a nice day. So that's a huge thing. Obviously, if you injure your airway, this patient's going to have air that extravasates, which would cause the crepitus. So use your anatomy to help you on these types of things. So you're going to see mostly respiratory complaints in the question stem. You're going to see crepitus. You said something else that was good. What did you say?
Like lung sounds?
Yeah.
Like so different lung sounds?
You will, so the lung sounds that you'll find on the USMLE are not going to be uniform for the tracheobronchial injury. Sometimes they'll say that sounds like there's a consolidation. Sometimes they'll say that there's some crackles. So you can't really 100% go by what type of lung sounds they give you. But usually they'll say patient has, let's just say, chest CT findings of subcutaneous emphysema is a big buzz phrase that they'll use for this. Sometimes these patients will even have like pneumomediastinum, like overtly, which can cause cardiovascular compromise, obviously, from the changes in pressure. I'm trying to think of what else that you can see with this. If they get bronched, one of the things that you can see on bronchoscopy is the patient will have irregularity of airways. They'll sometimes give you something generic like that to show that there's a disruption. Those are pretty much the major things. Do you know what can happen if somebody has an untreated tracheobronchial injury? Well, these patients are for sure going to get infection. They're going to get pneumonia because leaving open your airway to your mediastinum. You can get mediastinitis. Basically, you're just looking for airway stuff. You could even get bronchiectasis, stuff like that. Those are really the main things I think of a tracheobronchial injury. Sorry, my cat is just like trying to go in and out every 10 seconds. All right, next we got cardiac contusion, pulmonary contusion. You're going to want to use your imaging pretty much to solve these types of questions. So pulmonary contusion, they do give you some pretty definitive findings usually on the USMLE. They'll say that there's usually opacification of lung field within 6 hours, and these patients usually end up getting shortness of breath and often need intubated if severe or bilateral. So that's your pulmonary contusion. Cardiac contusion, you can even see this on your EKG findings of injury. The big thing here, so this could be any kind of S changes that are generic. So they'll have just ST changes and basically like non-contiguous leads, or they'll have it in diffuse leads just because it's just the heart's literally in stress. The big thing that you'll see is troponemia. And so this is just due to release from injured cardiac myocytes. So you'll almost always have this on the test, and they'll try and throw you off for an MI. So you want to look for the history. There's going to obviously be the big clue here of some kind of a blunt thoracic injury. So a patient was in a car crash or something like that. And then look for the elevated troponin. Other things that are kind of like on the same boat here would be like an esophageal injury. These patients, you're going to see same thing, pneumomediastinum that we talked about. These patients need usually an EGD. So get an esophagram for an EGD. Those are really the major things. Does that help at least answer some of those questions that you had, Amy?
Yeah, it does. Thank you. They were tripping me up in the question stems. They got confusing after a while. I kept mixing them up.
No problem.